Mri.
Okay, good. Hopefully I'm audible. You can hear me. Thank you, Dylan, for the opportunity to be able to participate in this. We've tried a few times to do it, so it's quite nice that we've finally got it together. Also want to say thank you to Cara and Madeleine for your input. Dylan, the thing that you put out asking for questions I found quite useful in trying to sort of put together my slides. I know there's a lot to be said, so I'm going to just muck on. Hopefully I don't take up too much of the time. So as you can see, there's several journal articles here that I used in putting together my presentation. I would just highlight the top ones on the left and the right, which are from South African authors. And in particular, I'd like to credit Prof. Rob Dunn with being a world recognized authority on TB spine. I've also included articles by Rajasekaran and Jane, which should be fairly well-known names to some of you. Okay, so I've been asked to talk about epidemiology, diagnosis, and treatment, or surgical treatment. As a result of questions that you have asked, I did put in a slide on prognosis and who you should refer, and we'll go on with this. So first of all, epidemiology.
Sorry, Nori, can you hear me? You just broke up there. I don't know if it's me or if it's you.
Okay, can you hear me better now?
Yeah, that's better. We got you back.
Okay, so starting off then with epidemiology, the World Health Organization in 2016 had South Africa as the highest reported incidence country in the world for tuberculosis. And looking at the electronic TB register, in 2015, HIV had a co-infection rate with tuberculosis of well over a third. So horrible statistics and world leaders, unfortunately. So statistically, 1.3 million people die of tuberculosis annually. And the effect of COVID on this is obviously still to be seen. Of tuberculosis, 10% is extrapulmonary, and of the extrapulmonary, 50% is musculoskeletal. And of musculoskeletal, it's most common in the spine. There are different types. Paradiscal and non-contiguous are what I'll largely be talking about, but Corin has a nice slide on classification, which we'll look at just now. So the high incidence, why is that? Well, the usual poverty, poor nutrition, poor access to health facilities, maybe should add there sometimes poor access to tertiary health facilities, certainly in the Eastern Cape. And then, of course, the association with HIV. The graphic shows that sub-Saharan Africa accounts for 70% of global HIV infection, which is quite scary. Just look at the interaction of HIV and tuberculosis. So HIV reduces cellular immunity by preferentially targeting TB-specific CD4 cells, and TB accelerates replication of HIV infection with these cells increasing virus production. So I mean, it's a bit of a vicious circle. Coming on then to spinal tuberculosis, we know that it's hematogenious spread, and it's either arterial or venous, and most often coming from lung and genitourinary tract. There is a spectrum of involvement, but by far the most common is paradiscal bone destruction resulting in kyphosis. So just to expand on that a little, the thoracic spine has a normal kyphosis. If you look at the lateral of a person or lateral X-ray, and as the paradiscal bone becomes involved and damaged by tuberculosis, it becomes softer. And because the body weight is anterior to this, it means that the anterior body is more stressed than the posterior body, hence the collapse of the anterior body resulting in kyphosis. Okay, so the kyphosis we get is due to vertebral body damage with preservation of the disc until the later stages of the disease. Okay. Cord compression is a result of the kyphosis, also because of epidural pus and disc and osseous debris. Okay, then late onset paraplegia, this is quite important. Late onset paraplegia is also known as paraplegia of healed disease. It's where the cord is tented over the kyphosis. And if I had to just show you with my laser pointer there. So if the cord there is, the yellow cord is being tented over the kyphosis. And this results in pressure in the cord and what's called myomelacia. Myomelacia is actually, the word myomelacia means softening of the cord, okay? And if you look at an MRI picture, it's a high signal T2 picture within the cord. And the problem with it is that it's irreversible. So if you do develop this internal gibbous with stretching of the cord over the vertebral bodies, as you can see in the picture, you can get irreversible paraplegia. Or anyway, so it is important to control or correct this kyphosis. So that's really what I'm trying to say. Okay, the article from the Western Cape over a 4-year period looked at a whole lot of consecutive cases. The point I'm really sharing this is really to look at the need for corrective surgery and the temporal trends with children. So as you can see on my slide, corrective surgery was needed in only 25% of adults, but in 47% of children. And the temporal trend over the 4 years, every year there appeared to be a reducing number of adults presenting with tuberculosis involving the spine, whereas in children, this was not the finding. So children with spinal TB, well, the disease progresses more rapidly, and it's thought partly because of a higher percentage of the spine is still cartilaginous, and they have a much higher.
Sorry, Nori, we seem to have lost you there again. Can you hear me?
I can hear you well.
Dylan, I'm hearing fairly well here. I'm not sure if it might be on your side.
And us again?
Dylan?
No.
I've been able to hear Nori very well.
And I'm hearing him loud and clear here as well.
Oh, sorry, so it's me. Okay, all right. Sorry, carry on.
Okay, no worry, I'll carry on.
Yeah.
So I was saying that in children with spinal tuberculosis, that the disease progresses more rapidly than in adults. And I was alluding that to a higher vascularity and a higher percentage of the skeleton being cartilaginous as opposed to bony, and therefore softer. I will talk a little more about the risk, the at-risk signs later on in my talk. I do think it's important to mention that deformity can become more severe due to continued growth, even in the healed disease. Okay, and if you look at Jane's article, which is a very good article, he describes the patients with the worst progression of kyphosis are those who have had radical anterior debridement. And he recommends that we try and avoid anterior radical debridement in children. So because of the continued deformity with growth, we need to follow these children up to skeletal maturity. Okay, my point. So this moving on then from epidemiology to diagnosis. So the clinical features, well, it is a delayed presentation. Now I know you have asked, how do you diagnose this early? Unfortunately, it has an insidious onset. So in most parts of the world, patients present 5 to 11 months history of not being well, but that's when they present. And we can say it's poor access to health facilities. I'm sure that does contribute, but the point is that it does take quite a long time to get to the stage where people seek help. And so if you look at the symptoms, probably the most specific to worry about tuberculosis is loss of weight. And again, Karen in her presentation will talk about that. So the signs of fatigue, pyrexia, night sweats, generalized aches are fairly generic and not specific to tuberculosis. So have a high index of suspicion, of course, but ask specifically about weight loss. And then remember the red flag of night pain. So backache with night pain, infection, tumors, that would be, but night pain is worrying. So if a person presents to you and they say when on asking that they've had pain at night, worry about it. Okay, with regards to the back pain, range of intensity from being hardly noticeable to being incapacitating. So it's obviously, it's not one thing or another, it's everything. with regards to weakness, my statistic there of 23 to 76% is of neurological. I mean, I don't think your patient presents saying I've got neurological deficit, but they will come in and say I'm feeling weak. I'll talk about that a little bit more just now. Okay, then, that's history. Then clinical features, the picture of the girl with the pink shorts, spinal prominence with a gibbous. The paraspinal abscess, that's the girl who's got that swelling in her neck. There's a paraspinal abscess can present anywhere really, but cervical spine, it can present as a swelling, but remember that it can cause hoarseness, it can cause respiratory distress, it can cause dysphagia. In the thoracic spine, clinical paraspinal soft tissue swellings are seldom evident. In the lumbar spine, where the pus decompresses into the psoas muscle, that tracks down into the groin, and you can have swelling in the groin or the thigh. And just as a clinical test for psoas abscess would be the patient who's comfortable with you flexing the hip, but uncomfortable with you extending the hip. So if you did a Thomas test where you flexed both hips and then extended one at a time, if they got pain on extension of the affected side, that would be a sign of a psoas-related pain and perhaps a cold abscess in the psoas. Then the clinical features, well, as I said, neurological deficit is present in a high percentage of patients on clinical presentation. It's higher in the cervical and thoracic spine, and that's partly because of the space available for the spinal cord is less in those areas, and also because it is the cord and not the cauda equina, which is lower down. And then talking to the thoracic spine, there is a normal kyphosis. So I mean, that tends to develop more in the thoracic spine involvement. Now, this neurology is usually incomplete. There is significant sensory sparing. So I mean, you may well find that the presentation is of motor involvement predominantly, of varying degree, with sensory sparing. Okay, then with lumbar disease, the weakness and immobility is because, remember, the lumbar spine is lordotic, not kyphotic. So it's most often that the weakness that the patient complains of at presentation is due to pain rather than due to neurological compression. Laboratory studies, the full blood count, there may well be an anemia, which is just a sign of chronic infection. The white cell count is invariably normal. Koshi Daniel and Prof. Dunn did a paper published in a European journal which showed the raised platelet count of patients with tuberculosis. I like to punt that one. And lymphocytosis, if there is a problem, it's usually elevated, except in HIV positive patients where you might have lymphopenia. ESR, I know there's going to be talk about that. We use that, and it's almost invariably markedly raised, and we use it not just to diagnose, but also to monitor. And we realize that in HIV, it's not so helpful. And then as a laboratory study, thinking in terms of either using sputum or urine for gene expert, because we know that primary often comes from those sites. Imaging, X-ray can be suggestive of TB with the various things I'll talk to, but the definitive diagnosis always requires laboratory confirmation. Now, X-rays are readily available. I think most of you have got access to them most of the time. And if you look at my laser, you can see this fusiform swelling around the thoracic spine, which you can look for. It's obvious in this picture, but I mean, sometimes it's a bit more subtle. Understand that tuberculosis in the spine is invariably, when it's active, is invariably osteopenic as opposed to sclerotic. So if you start seeing sclerosis, then either your diagnosis is wrong or you've got healed disease. Okay, so it's osteopenic. So the bone destruction we've spoken about already, causing the kyphosis. There's disc height preservation, although it's not always apparent on a plain X-ray, more obvious on an MRI. Okay, then the soft tissue presentation of TB involving the lumbar spine into the psoas muscle may not be visible on your X-ray. Just the graphic at the bottom here, marry the posterior elements with the body. So if you look at the three pictures that I have, you can see there's half of the body involved in the left picture. There's a total body involved of one vertebra in the middle, and there's two vertebral bodies completely involved on the picture on the right. And that's important in terms of prognosis for progression, which I'll come to later. Okay, MRI scan, well, it's the most sensitive and specific, and given choices, everybody now would ask for an MRI. You can look at the cord compression by the pus and debris. You can talk about intrinsic cord signal changes. You can see whatever disc destruction there might be, and probably most importantly, you can see whether there's non-contiguous involvement or not. And we know in the literature that up to 16% of patients with spinal tuberculosis have non-contiguous lesions. CT scan, more easily accessed. I can get it, quite often I can get a CT scan done in my clinic on the day that the patient comes, whereas MRI, big deal, got to admit the patient, takes a week or two. So I mean, CT scan, obviously more easily accessed. For me, this picture was always an Aunt Minnie. I know my Aunt Minnie because I recognize her when I see her. So I recognize TB spine on a CT when I see it. But this epidural involvement with paraspinal abscess and this calcification is so typical of tuberculosis. I have got on my slide differential diagnosis of pyogenic Dyskitis. Just understand that bacterial Dyskitis presents with acute symptoms, with acute pain, and on X-rays and investigations with disc involvement and preservation of the vertebral bodies. Okay, so it can be tricky, but there are some telltale signs that you can look for. On one of your questions, you asked about the use of ultrasound. I must confess, didn't see much on ultrasound on the articles that I read, but I do and have often asked for ultrasound to diagnose the psoas abscess, which is a feature of lumbar disease. So for me, that's what I tend to use it for. Okay, so moving on then to biopsy. Biopsy can either be CT guided, percutaneous, or open. I don't think any of us in the Eastern Cape have got access to the CT guided one, so it's all done open. Okay, let's talk about biopsy. So biopsy is mandatory because you need to do a biopsy to differentiate tumor and other infections. Okay, and if you do a biopsy, then your tissue has a higher yield than pus. So if you can send tissue away, that's good. Culture remains your benchmark, but it takes 6 weeks to get a culture. And as you all know, tuberculosis in the spine is paucibacterial, which means there's not many organisms present. So you may well find that on your histology and on your culture, you don't always get it. The yield at UCT was only 38%. You can make your diagnosis based on histology of a caseating granuloma with giant cells, etc. It's 60% UCT study, but just remember that conditions such as sarcoid and cat scratch disease also present with caseating granuloma. So it's not specific, but it's enough to be able to make a diagnosis and start treatment, if that's all you've got. Okay, then using the PCR or gene expert, we know its specificity and sensitivity is in the region of 90+%. And we know that gene expert technology is available with a diagnosis within 2 days, which makes it really attractive. And in addition to this, it does help you, especially only with rifampicin, it allows you to diagnose resistance or not. And the UCT guys, Rob Dunn has said that they haven't had any patients with resistance that wasn't resistant also to rifampicin. So if your gene expert shows that you're not resistant to rifampicin, then according to the Cape Town statistics, you've got a sensitive organism, which is quite helpful. Okay, I've mentioned on your histology, your granulomas, a few conditions can mimic that, but other conditions to think of, with regards to night back pain, etc., malignancy, other infections, pyogenic Dyskitis was spoken about, MOTS, which is mycobacterium other than tuberculosis, and brucella and hydatid would be conditions to think about. Treatment, well, I know Madeleine's going to talk about treatment, but it is important to say that medical treatment is the mainstay of treatment for TB spine, and even 40% of your cord-compromised patients improve on medical treatment alone. Okay, I mean, I need to say that because access to surgery isn't always possible, and there are complications from surgery, so there are issues with regards to doing surgery. But surgery is indicated for specific conditions, and regardless of whether you have a biopsy or not, especially in poor resourced areas, start your treatment early, even if it's only based on your clinical findings whilst you're persevering with trying to get the other bits and pieces done. So what is the response to treatment? Well, it's relief of pain. It's resolution of neurological deficit. It's an ESR or a CRP returning to normal. Importantly, it's weight gain, and it's X-ray signs of healing, which, as I said earlier, shows sclerosis. Okay, so let's go on. So your indications for surgery include doing a biopsy. Now, unfortunately, in under-resourced areas, it's the surgeon who's responsible for the biopsy. Then an indication for surgery might be the presence of a large abscess. Remember, the disease is paucibacterial, and it takes a long time for the antibiotics to penetrate the abscess. So Madeleine again is going to talk about the duration of treatment, but patients with large abscesses, if they don't get treatment, need longer durations of chemotherapy. Deformity, yes, there are indications to either correct the deformity or prevent the deformity, and I'll go into that. And then neurology, if you've got worsening neurologies despite treatment, then that would be an indication for surgery. Having said that your options are always determined by surgical skill, post-op facilities, and access to theatres and bed availability. Now, in preparation for this, did phone I phoned Port Elizabeth and had a long chat with Martin Potgieter, who's a spinal surgeon there, and I had a chat with Lonwabo Mweni in Mthatha, and I obviously know the situation at Frere. So just if I had to compare the three centres, it's pretty obvious to me that Port Elizabeth is blessed with having a dedicated spinal surgeon, with having 1.5 theatre days a week dedicated to spinal surgery, and access to good orthotics and prostheses with regards to bracing. So if you happen to be listening in and you come from the western region of the Eastern Cape, you're probably more fortunate than those from the eastern and the central regions, but that's just the way it is. Okay. So the advantages of surgery include decompression, correction or prevention of kyphosis. It may facilitate fusion. They talk of faster pain relief and functional recovery, and a lower risk of late onset neurological deterioration. Okay, so let's talk then about deformity correction. This is one of the pictures that I showed you earlier. So deformity correction in the adult spine, if it's either established or predicted to go greater than 60 degrees, then you should operate to prevent that paraplegia of healed disease and myomelacia that I spoke about. So the formula at 5 years to predict deformity at 5 years is what I've written down there. So you divide the vertebral body into tenths, and then you work out how many tenths of each vertebral body is involved, and then of course how many vertebral bodies are involved. So you would get then the total vertebral body involvement, and then you would multiply that by 30.5 degrees and add another 5.5 degrees. So as my example, you can see that there's 2 complete bodies that have been destroyed there. So it's 2 times 30.5 plus 5.5, which comes to 66.5%. So if you had to take a rule of thumb, if you've got 2 vertebral bodies that are completely involved, then you should really proceed to operate to correct this kyphosis. In children, we spoke about the Radioseccarin spine at risk signs, and these are the 4. Dylan, when you did your thing that you sent out, this is one of the questions. I think most people got the question with regards to lateral translation right, but weren't that sure about the others. So let's just look at these then. So separation of the facets, which is A. Retropulsion. So if you draw a line along the first normal lower vertebral body, the back of the vertebral body, and a line along the first normal upper vertebral body, where those lines intersect, if there's body involvement behind where those lines intersect, then you've got retropulsion. Lateral translation basically is if you draw a vertical line up through the middle of the pedicle of the top normal in the lower segment, but the most proximal normal vertebra, if it doesn't go through the pedicle at all of the normal vertebra above it, then you've got lateral translation. And superior toppling, if you draw a line on the lateral X-ray along the anterior border of the first normal vertebra, it should intersect the first normal vertebral body above the deformity in its lower half. Okay. Right. So trying to show how to make that more obvious. But those are the 4 signs of spine at risk, and you need to look out for these on plain films. And I just need to tell you that with children, that progression in children can occur after healing, so you need to follow them up to maturity. Okay, then just with regards to the surgery, what do you do if you've got a patient who has minimal deformity but a large paraspinal abscess in the thoracic spine or thoracolumbar spine? You can do posterior surgery using a costrotransversectomy, which is an image that I've tried to put on the screen, and you could combine that with a posterior fusion. Okay, formal debridement and reconstruction of the anterior column is reserved for severe kyphosis or predicted kyphosis and cord compression, which is not responding to medical care. And certainly Cape Town, and we the same at Frere, prefer would be a thoracotomy anterior approach if it was involved between T6 and T11. But you can also do a posterior based approach, and you can access the front of the spine through the back, but you do have to sacrifice a couple of nerve roots. Okay, I don't think to harp on the surgery too much. In the thoracolumbar spine, I've tried it. I mean, I've done it a couple of times. It's really difficult. So Rob Dunn advises not to use an anterior approach. Pleased to hear that. So posterior surgery at thoracolumbar level. In the cervical spine, almost always an anterior approach, but if the end plates are soft, you might need posterior augmentation. Just remember that there's no contraindication to instrumentation in this infection because TB doesn't form a biofilm. And he and us as well, we use bone allograft as opposed to cages because the cost is about 10%. So we would use a humeral allograft for the thoracic spine and maybe a femoral allograft for the lumbar spine. And in some instances you use the patient's rib, although that often is too soft and it breaks. Okay, so let's move on then. I haven't spent much time purposefully talking about the surgery because I know the audience that I'm talking to, but the prognosis for TB spine is good, even when the patient has significant neurological fallout. So about 90% of the patients with neurology presenting to UCT who have appropriate investigation and surgery improved by at least 2 levels. When I say levels, I don't mean vertebral levels, I mean 2 levels as in the Asia score. Okay, so the prognosis is good. I don't want us to think that if somebody's become neurologically involved that they're a cripple for the rest of their lives. They shouldn't be. Okay, then my second line is prevent the paraplegia of heel disease with internal gibbers because they're getting the neurology with the myomelacia, and that's irreversible. And you must act on spine at risk signs in children. Okay, then my last slide is who to refer. Well, you should refer all of your TB spine because they need to have a biopsy. Now, whether the people that you refer your patients to are able to do the biopsy or not, is dependent on their workload and their availability of beds and theatres. So, you know, we're all constrained. I don't think it's all our fault when we can't admit and biopsy your patients, but I think you should refer, and I've spoken to the guys in PE and in Tata, and they go along with me. Basically, you know, we should be biopsying, so you should refer all of your patients that you think have got TB spine. You should refer your patients who are not responding to chemotherapy. They might be not taking the treatment properly. They might have resistant organisms. So, or you might have a wrong diagnosis. So you should refer those patients. And those patients who have radiological progression. So we've spoken about that on those couple of slides that I had. Dylan, Madeleine, Corinne, that's really all I've got to say. I hope I haven't overstayed my welcome here. Thank you.
Thank you very much, Prof. Dylan, would you agree that we leave questions for at the end? Just because I think people might anticipate us. If you do have questions, please start putting them in the chat so long. And then also please introduce yourselves so we can have a record of who attended today and just can see who our audience was. Just on the chat, just put your name and where you're from if you've not yet done that. Okay, I've just shared my screen. And we will have time for a little bit of time at the end of the questions to all three of us. So you've not missed your opportunity with Prof. Gibson. Thank you so much. My presentation is going to be much shorter because although medical treatment, as Nori has said, is absolutely probably one of the most important parts of spinal TB management, it's the least complicated part, actually. Although we will go through some of the things we know and some of the things we don't know. And basically the most important thing of the medical management of the treatment of TB spine is the earlier the better. So I think probably one of the big things for us in this talk is priming people to look for it, to think about it, to diagnose it early, to figure out which TB it is, and to get people onto treatment. And the earlier you get them onto medical treatment, the better the prognosis, the less chance for deformity, and the less chance for long-term morbidity. So I'm just going to repeat a couple of things around the confirmation. This is extremely important. And in that study from the Western Cape, Nori mentioned that almost 78% of patients had a confirmation of their TB. So quite often with extrapulmonary TB, we sometimes get a bit lazy. We make a clinical diagnosis, maybe the gene expert comes back negative, and we go down the route of just putting them on treatment and not doing effort to actually get that. So firstly, if you can get histology, you're now going to all start calling up your local orthopedic surgeons to get that histology, to get a culture and gene expert if there's anything that can be biopsied. Always do a gene expert on sputum, even if the patient does not have symptoms. It's always worthwhile. Our gene expert ultras are so sensitive now, and there might be some other PTB involvement. Because it's extrapulmonary TB, quite often they don't only have spinal TB, and therefore you can find a sample from somewhere else. If there's any glands infected, or if you can get any cells into a needle, if you're doing an FNA, for those of you that are not aware, from your NHLS, you can get small little TB culture bottles in which you can rinse your needle and at least send for a TB culture. So you're still going to start your TB treatment if you haven't found a sample from anywhere else. But at least 6 weeks down the line, if you're not responding to treatment, we at least have something that can tell us whether the patient might have resistant TB. And then something that Dr. Stead always recommends, especially with our disseminated TBs, is an early morning urine for TB culture. I need to check with them. I know they've been looking at doing gene experts on the urine, but the TB culture would be even more sensitive. Again, it might take a while to have a result, so you're not going to wait for that result before you start treatment, but it's good to have that in the back pocket before you start your medical treatment. And just to remember, in our area, probably 5 to 10% of your patients might have drug-resistant TB. And with spinal TB, we don't have time to waste. So you don't want to discover 1 month or 2 months down the line that your REFA4 has not been doing the trick. So try and get some sort of TB culture or gene expert off to find those drug-resistant TBs nice and early. So which regimen? This is the $1 million question. And you will find when you look at different studies, we don't actually have any solid evidence-based medicine that really tells us the most appropriate regimen or length of treatment. And because of that, there are different variations. Everyone agrees, though, that it takes longer to completely clear all the bacilli, partly due to the poor penetration of bone, but also particularly if there is large abscesses like Nori has mentioned as well. And so it's just how much longer, that's the question. Some of the studies that has been done, though, has shown that certainly doing surgical debridement, and they did a study where they compared surgical debridement with a 6 or 9 month course of treatment with an 18-month regimen. And certainly, if you have a large abscess, surgical debridement, you can get away with a slightly shorter regimen. So very important that if you do have a lot of material there, to see if you can get your surgeon to assist you with that. So I'm just going to go through the varied approaches. And actually, I am very happy to support different varieties. And I'm just going to show you what different people do in East London. If you go and look at what's happening more on the Western side, the standard recommendations and most of the guidelines on the USA, Europe side is standard Refafor for 2 months, and then a continuation phase. And they literally will say 6 or 9 or 12 or 18 months. And it's really thumbs up on how people decide whether they're going to give a 7-month regimen or 11-month regimen, or whether they're going to give for 18 months. And quite often it has to do with how severely your spine has been involved and how severe your deformity is. Interestingly enough, your WHO recommends still a standard 6 months, and feel that it's adequate to just do your normal 2 months Refafor, 4 months of refiner. I think in practice, very few of us who work in spinal TB are quite brave enough to do that. The American Thoracic Society has a 9 standard months, a 2 + 7 that they do. And then this amazing, yes, Professor Dunn, who is certainly one of our greats in South Africa and lots of experience with TB spine. In the Western Cape and UCT, they standardly use the Refafor all 4 drugs for 9 months. And so Frere Hospital is also following that approach. Some of you might be aware that things are slightly different on the CMH and Gqobelela side. So my experience is mostly from working with spinal TB in Gqobelela, and I've had a chat to Dr. Dave Stead as well. And it's not because any of us know better than the Frere side. It's literally just habit. So what's happening on our side is usually a 12-month regimen, but using the 2 months of Refafor and 10 months of refiner as your continuation phase. And occasionally, if you've got very mild disease or somebody that you've diagnosed very early with no deformity, you might give a 7 months of refiner for a 9-month regimen. So I know this is one of the things that we had a discussion about in terms of what should we recommend? Should we recommend the Frere regimen with all 4 Refafor drugs, all 4 drugs for 9 months, or the 12-month regimen? I think whatever orthopedic surgeon you're working with, or whichever site you're working with, whichever doctor sees the patient and starts the treatment, I think it's valid to follow that regimen, as we don't actually have evidence in terms of which is better. Certainly in patients who have very poor response or very severe disease, we certainly will extend treatment, and I will talk you through that in the next slide. And one of the things that are important, regardless of which regimen you follow, is that when you calculate your dosing, or when you look at your weight band for your patient, to actually use the highest possible dose according to the weight bands. You don't want to underdose these patients, and also watching them as they pick up weight during treatment. So say, for example, they're just under the weight band for 3 or 4 tablets, you'll probably go a little bit higher. So just the reason why on the CMH side, they do the Refafor only for the 2 months. So it's more about a theoretical concern about giving ethambutol for 9 months. There's a very, very low risk of optic neuropathy. We obviously give 9 months ethambutol for our MDR patients all the time, and we don't often run into trouble. But it's again this, if we don't know whether it's giving extra benefit, should we give it or not? The other thing that we see more often is side effects on the PZA. So a lot of people get joint pains and muscle pains on the PZA and don't tolerate it very well. So one can individualize it as well, depending on what's happening with your patients. But those are your 2 different options. And I certainly wouldn't go less than 9 months. And if you are going to do 9 months, to rather do the 4 drugs, otherwise do a good 12-month regimen for your patients. So now, how do you monitor what's happening? And Nori already briefly referred to that. So part of the normal indications, or our national department government program to monitor TB, is still doing AFBs. Although AFBs is not going to be very useful for your standard spinal TB patient. They're not going to be coughing up lots of AFBs, but usually AFBs are still supposed to be done at 7 weeks of treatment and 1 week before completion. And that's more to do with our epidemiological recording of these patients. But what you're going to be able to, much more important, is monitoring is on the symptoms. So you want to specifically look for your constitutional symptoms to die down. So your night sweats and your fever within a couple of weeks must already be completely gone. And your most important thing to monitor is your weight gain. So it's your easiest objective measurement of whether your patient is responding to medical treatment, and for you to be able to identify early whether you might be running into trouble. But the other thing is also the clinical improvement of the actual either neurological symptoms or certainly of the localized spinal pain. So try and keep a record and get the patient to give you a score out of 10 in terms of what's happening with the pain, and give good neurological, do a good neurological examination and recording of what you're finding on examination, so you can actually plot any changes over time. So the other thing is always the whole CRP, ESR discussion. I actually think it doesn't matter. It's whatever your habit is. Both of them are good. It's certainly acceptable practice to use inflammatory markers to give an idea of how much inflammatory activity you still have in that spine. So the ESR is a little bit less reliable in patients with HIV co-infection. It might muddle you slightly, but ESR is still traditionally used in many settings where it's available as a bedside test, which makes life a little bit easier. Otherwise, CRP is also very acceptable. Don't do both, that wastes money. But and that we use to actually be able to tell us whether our disease is still actively attacking that spine. So what tends to happen is you'll start your patient on your whatever regimen you're going to use, and say we're using the 12-month visit. Then at your 12-month visit, you're going to be checking for the following. Is their systemic symptoms resolved? Have they had good weight gain? Has the CRP normalized? And then Nori also mentioned you will then do your x-ray and you will see if there's signs of healing. You want to see that bone is busy recovering. And so for the first time now, you want to see evidence of sclerosis. If you see all of that, you can say, great, we have successfully medically treated. And then at this stage, you can decide to stop your treatment, and then you'll review your patient on a 3-monthly basis, where you're going to be looking for systemic symptoms of TB. So you don't want to wait again till the spine flares up. You want to start seeing any signs of your TB flaring up. And I would follow up a patient for a good 1 year or 2 years. Just if you don't obviously have any of those things and you're not sure, that's when people will normally extend the treatment, and they would normally extend with 3 months at a time. So you can't talk about TB until you've talked about HIV. And so just a reminder that your HIV management absolutely essential. Spinal TB is a stage 4 disease. So we would start within 2 weeks of having started your TB treatment if you're initiating a patient for the first time. And it's important to get the ARVs on board. So this is just from the new guidelines. Most of you might be aware of that. So we now all have TLD available, which is great. But the recommendation in the guidelines is if you're starting somebody for the first time on TB treatment, your preferred regimen is still TFE. Your tenofovir, imitricitabine, and efavirenz is still an excellent regimen. And it's easier for the patient to take because it's a once daily tablet. If the patient's already on a dolutegravir-based regimen, remember that you have to boost your dolutegravir with the extra 50 milligrams per day because you are combining it with rifampicin. And of course, if they're on a Eluvia-based regimen, remember you're going to have to double your dose of your Eluvia again because you're giving it with that rifampicin. And the most important thing is make sure your viral load is suppressed. So keep an eye on that viral load. Make sure your viral load at 3 months is suppressed if you first started your ARVs, and your goal is to keep them virally suppressed throughout their treatment. I've got I think a last quick slide just on paradoxical iris. So this is one of the questions that has come up around spinal TB. So your worry is that you've got a spinal TB patient on treatment. Hopefully you have a confirmation that it definitely is drug-sensitive TB, so you know they're on the right treatment. You know they're taking their treatment. Hopefully you have some treatment support, but your patient is getting worse. So either any of their signs or symptoms might be getting worse, but the most common TB iris we still see is actually increased weight loss. And of course, a big worry is if you already got somebody that has got some spinal attack by the TB, that suddenly some of those symptoms are getting worse, or some of that deformity is getting worse. And the question then is, can we intervene or not? Now, we don't have much evidence of the use of steroids specifically for TB spine iris, but there is more and more evidence of using steroids for TB irises in general. And we don't particularly like using steroids in TB if we can, but certainly with particular areas where your inflammation is doing more damage than doing damage that you're not going to be able to reverse, you actually do want to consider that. So for example, we tend to use it quite a lot in lymphadenopathy iris when you've got huge glands that are starting to get bigger collections and starting to break down and cause sinuses or threatening to cause sinuses. We also use it very successfully in patients who have recurrent pleural effusion, so a pleural effusion that keeps on filling up every time you've drained it because of that inflammation. And so there's a strong case to be made, certainly at Nkobela, if we got concerned about spinal symptoms getting worse, we would use a course of steroids. And the classic way of doing that is your prednisone 1 to 1.5 milligrams kilograms per day, usually the 1.5 because we're using it with rifampicin, and you do it over a 2 to 4 week periods of time. And so far it seems that the benefit certainly outweighs any possible risks and is worth a try if you are concerned. Just make sure you do have a bacteriological confirmation that it is actually drug sensitive TB, and that you're not giving steroids to somebody that actually has a missed drug-resistant TB. So my last golden takeaway messages here is diagnose early. Please get a microbiological confirmation, even if you just have one in the pocket with a TB culture from somewhere. Start your medical treatment nice and early and follow up closely to make sure they're responding to treatment. There's just some of the resources, although we were all sharing around those lovely articles that, that Prof. Gibson was showing. I'm going to actually hand over to Karen now because she's actually going to cover some very important bits, which I want to give her as much time as possible. And then we'll have some time for questions at the end. So Karen, I'm going to hand over to you. Just keep going. And I'm going to ask people to keep on putting questions in the chat, and then we'll put it all together as we get towards the end.
Okay, thanks everybody. I'm Karen Galloway. I'm a physiotherapist. It's fun to be here with Prof. Gibson and Madeleine. Yeah, I have experience working in our Tambo district at Setulele Hospital. So my context is that side of the Eastern Cape. And obviously some of you working in different areas will have different experience with the place where you are at. Let me just see if I can share my screen. Can you see all that? Can you see that? Can you see my screen?
It is sharing. We can't see it yet, but it's coming. Yes, there it is.
Okay. So yeah, so as a physiotherapist, often you'll be involved with TB spine either from the front end or the back end. And in my time at Setulele, I just kind of developed a bit of a passion for getting it early, because early detection is so much. It provides so much of a better outcome for patients than the late diagnoses, which can be more disastrous. Although, as Nori and Madeleine said, the medical intervention is quite effective and people often recover nicely, even if they look like they have a bad neurological outcome. So my presentation is about how to, as a physiotherapist particularly, or anyone in a frontline, like a clinic setting, presenting with someone with back pain, how do you, what can you use to distinguish that from some normal pain? So we'll see how it goes here. I'm not winning with my...
Click on the screen, and then there we go.
Yeah. Sorry, I'm not getting here. I'm just gonna have to, can you see that now? I'll just have to do it like this. Oh, goodness. Okay, sorry, I'm just struggling with the screen sharing. Can you see it like that now? I'll just carry on down the screen like this.
Hang on, yes, it's there.
Okay, so most of my talk comes from the paper that I published in 2018, and it's basically all of the reference are in there, so you can have a look in that if you're interested. It's basically trying to get earlier diagnosis at primary care level. So when the quiver full of arrows, sometimes just doing a decent subjective assessment is helpful. When someone presents with a back pain, obviously you don't want every single person who has back pain to be suspected of TB spine, but one of the good questions you could ask your patient is, are they more concerned about this spinal pain event than usual, and why are they? A lot of people in their life have had back pain, and they might have their own reasons for being more worried about it than not. A lot of my points are going to repeat. This is the joy of coming third in the presentation, but just practical examples. So loss of weight, you might, I learned not to trust clinic scales. They sometimes don't compare between clinic and hospital. So ask the patient if their clothes are looser. You can also measure upper arm circumference, which is a nice reliable way of checking whether their weight gains or doesn't when you measure them on another scale. And then constitutional symptoms, if you're relying on night sweats and a fever and loss of weight, sometimes that doesn't happen. So even up to 61% of patients with TB spine presented initially only with pain. So sometimes I think we don't think of TB spine because we're expecting the classical symptoms and they're not there. Obviously the red flags, children who complain of back pain, and so as we're talking about spinal TB, people are often thinking of thoracic and lumbar, but you do get cervical TB spine, and it's often not identified because it presents in an atypical way. Immunocompromising states, we always think HIV, but remember pregnancy, being elderly, drug and alcohol abuse, steroid treatment or organ transplant, and even poverty are immunocompromising states. And illnesses, the big three, diabetes, HIV. I mean, you think of the autoimmune ones as well. And then back pain that goes on longer than 3 months, or an age of under 20 or over 50. The physical exam, I know everyone's busy, but just doing a decent physical exam, actually taking the patient's clothes off, looking at them, looking for flattened curves. Nari explained about how the kyphoses work. If you're looking at someone and they've got back pain and they might move quite easily, but actually they've completely lost their lumbar curve, that's significant. Even feeling along their spine, you can feel autonomic skin changes. So palpate their skin, palpate the area. Don't poke them too hard. Some people are rough. Check their movement. And the other thing that I found was a little bit significant and is finger point pain. If someone puts a whole hand on their back, like I've got general back pain, then that's not a warning sign to me. But if someone points with a finger and they go, it's really sore here, then that's a specific and localized back pain, and that could be significant. Early neurological symptoms, if you do a neurotest, you can see them. Sometimes a mild neurological loss is one of the first indicators. The very first indicator can be a loss of vibration sense, which you can do with a tuning fork, but most people don't do that. But just basic sensation, proprioception, checking their motor control, reflexes, clonus, and look at the movement and why they've lost function. Cord equinus symptoms, Nari explained about the lumbar spine. Just remember, it's not your spinal cord ends high up, and it's cord equinus symptoms. So you're not going to get, you're going to get different presentation than you would with an injury to your spinal cord high up. So urinary and fecal incontinence or retention, that includes stress incontinence, and just check if they're having repeated UTIs. That's another thing. Subtle anesthesia, bilateral loss of reflexes, power, sensation, and severe night pain. Nari mentioned this as well. Exclude the positional thing. Some people have severe pain at night when they turn, so you need to ask them exactly when and how the pain is. These are signs of worsening cord compression. Oh, sorry, let me just go back. And then there are a few tests to add to the quiver, and these have been mentioned already. So if you are thinking perhaps this back pain or this spinal pain is atypical, or you have reason to be concerned, and normally it's a good idea to kind of know what a normal back pain and a normal course of healing would look like, then you can add the pulmonary TB, looking for pulmonary TB. When you do a spinal x-ray for someone who is suspected TB spine, do a chest x-ray as well, because typical changes on chest x-ray are going to help you to add that to your thinking about TB itself. And then gene expert Madeleine talked about that. There's lots of concomitant pulmonary TB with spinal TB. So if someone even isn't presenting with pulmonary symptoms, just remember to get that as something, you know, if you can get as many things as you can that could give you a positive indication, or rule out a negative, including that. So Nari mentioned some of the differentials. Just if you can exclude the common cancers for men and women in certain ages, then that's also helpful if you use that as a screen. HIV and ART history. a couple of times people have been put on ARVs and then later on come in with back pain, and you have to think that this could be an iris. So just keep in mind the time frames and the timelines. And then ESR and CRP have been mentioned. And then the spinal x-ray, a lot of people who are involved in spinal research and TB spine, they talk about taking the full spinal x-ray. Don't just stay at the one level, rather x-ray the whole spine when you've got them in there, so that you can see non-concomitant, so a TB spine that's not at consecutive levels, but jumps. I mean, they call them skip lesions as well. Those are actually common. Not very common, but they can be common in certain cases. And remember that the x-ray will not show the full extent of the severity, and an x-ray that's clear doesn't exclude extradural TB spine. So spinal x-rays are good, but they aren't absolute in terms of their diagnosis. So just remember that they have limitations. If you don't see the classic presentation on x-ray, it doesn't necessarily mean that TB is not there. So TB is a tricky one because you can't definitely exclude it. You can't definitely always include it. So this is why the whole quiver full of arrows approach seems to be better. Abdominal ultrasound. If you have access to ultrasounds, and most rural hospitals have a ultrasound machine in maternity, and if you're lucky, you have an ultrasonographer or a doctor who's trained in ultrasound, and they can be really helpful. So you can look for other suspicious nodes, and obviously that's just another thing to add to your clinical reasoning. The next slide is about the different presentations on x-ray. So the first one on the left is paradiscal. That's the most common. 80% of TB spines present with this one, and this is what everyone looks for. However, you need to bear in mind that TB spine on x-ray can look like that central lesion. It's not as common, and anterior also not so common. And the posterior between 2 and 10% in some of the literature. So also bear in mind that TB spine can look like that. And the extradural tuberculoma is not seen on x-rays because obviously it's extradural. And the skip lesions, you can get lesions that aren't found alongside each other, but they jump from spinal level to spinal level. And that's why it's always useful to do the full spine x-ray. Knowing where the different infected areas are also give you an idea of how severe the infection is. And Prof. Gibson was talking about, if it's multiple levels, then you'd consider referral. And so if you have a look at the whole spine, then you might find it's more extensive than you initially thought, and that would also possibly influence how much treatment you would get, as Madeleine was talking about, the length of time of treatment. So once you've evaluated all of those little things that you can see and dig around for, then you can consider all of those elements, whether they're positive or negative elements in it, and the story, the longer story, not the short story. Hello, doctor, I've got back pain and you prescribe Panado. But the site of pain, does the site of pain match the mechanism that you're suspecting? And are there other tests that you can add to the hypothesis? A normal spine pain should follow a predicted course of healing, complicated by certain factors, including yellow fags and occupational issues and grant requests and things. But it is helpful to use a spine at risk label. Sorry, Regis Karan's spine at risk thing is about unstable spines, but the spine at risk label is if you see somebody who's got back pain and you have a level of concern, write down on the follow-up card, not back pain, but back pain, please follow up, possible spine at risk. Then they don't get a faulty label, but the next medical professional who sees them will maybe have a look at it and go, oh, let me just ask a few extra questions, take a few minutes with this one because the person had been more concerned. Whereas if you say question TB spine, and sometimes people don't read the question TB spine and they just dive down the treatment route. So having a different sort of label can be helpful. And then quickly, sorry, those people who have actually got confirmed cases of TB spine, obviously it can present as all sorts of different severities, but basically, regardless of the severity, if you imagine yourself getting a diagnosis of TB spine, you've got an uncertain future, knowing that your life's going to be altered in certain ways, regardless of whether you have a complete healing or not, you're still going to have a period of time swallowing lots of TB pills. So you need to understand the person with the disease, understand their life to which they're returning, and provide mental health support and motivation. A motivated patient is more likely to stay alive and complete their treatment and win. And you need a team approach. Treatment interventions, I wrote at the bottom, being alive is the best rehabilitation. There's no point in having the best elbow flexion you can get if you're dead because you didn't follow all of your treatment. So make sure the treatment path is followed. And then I'm speaking as a physio, any of the physios, OTs, or rehab staff who are following up, and obviously the nurses and the doctors as well, you need to make sure that they follow up the treatment, the post-surgical management. If they're on ARVs, they must obviously continue with that, bed rest, etc. And then all the stuff that kills people, if someone is immobilized for a bit, like pressure sores will kill them. Continence, being incontinent will increase your risk of pressure sores, and that'll kill them. DVTs can kill them. And then preventing respiratory compromise and death, especially with cervical spinal TB. That's something that's sometimes, yeah, I don't think it's as commonly diagnosed as it happens. And then you need to educate your patient about what progress will and should look like. As much as you would do for HIV, you'd expect them to know the viral load and things. So you'd expect a patient on TB treatment to understand how they should get better. And then help them to manage the pain, but don't forget the clinical usefulness of pain. Pain is a good indicator of healing and pathology. And then ambulant chemotherapy, and as we mentioned, most cases of spinal TB will be in this group. Spinal TB is considered a stable fracture, except for those people with those signs of the spinal instability. Nori shared that slide. Roger Sekaran's indications of spinal instability are really helpful. So if you have a patient that you think has any of those indications, they definitely are candidates for referral. And people keep asking about whether or not we should brace. Bracing an unstable spine is patching something, but it's really not the solution, and that should be the case only with a rejection of further interventions by someone further up the secondary tertiary chain. And post-surgical management, post-surgery, and the surgeons always have their own opinions about how they would prefer things done, and the best is to find out from your surgeon exactly what the protocol is that they want followed. Occasionally you'll have indications of restricted bilateral arm movements or bilateral leg movement, depending on the level of the injury. And it also depends on the surgeon. Some feel like once they've provided the spinal stability, it's pretty stable and you can move forward quite quickly. So it can vary very much from surgeon to surgeon. Bracing. So let me just say a thing about braces. The braces that you get that are those little material ones with the a little bit like an olden day corset with what are those things called? Those little plastic struts in them. They really aren't effective for physical function. If you're wanting a patient to be reminded that they have a TB spine and they can't be reminded by the pain that they have, then you can use one of those. The bracing indications are for people with severe pain or people at risk of kyphosis progressing or evidence of lateral instability. But like I said, a lot of the people in that category should really be referred on and shouldn't be managed with conservative treatment unless there's an indication from the tertiary centers that they're not accepted. And that has happened, and it does happen. And if you're in a rural setting and there isn't an opportunity for those people to get other support, then what we ended up doing was using our budget, which we didn't have. So we borrowed budget from somewhere, and we bought 10 OSA adaptable TLSOs, and they're adjustable, so you can use them on different patients, and you just clean them when they come back. But they're very good quality, and they provide decent structural support. And those are the ones that would be provided for patients who you feel are more at risk. They've got multiple level spinal involvement, and they can't get other support from another center, even if you feel like they would be a good candidate for surgical support because of the multiple level or the risk of kyphosis, then those are the ones who would be getting that good quality brace. Brace compliance is a tricky one. You need to use it carefully and follow up to make sure that people are actually obliging. The patient who is has a good understanding of the consequences of not bracing will be compliant, but it is very uncomfortable, and the braces have to fit very well. And that's also sometimes a problem in certain rural sectors. Brace until the pain resolves generally, and weaning is required. If you just say to someone, well, you need to take your brace off, and they won't have the postural endurance to support that, and then they will fatigue and they'll get sore. So you need to wean them off properly. And then obviously you need to have signs of improvement of disease, and some advocate just standard brace for 6 months, but it's kind of a bit of a shot in the dark. So yeah, so you need to, with all of the patients with TB spine, especially those with more severe neurological involvement. Managing risk of secondary complications is really important, as I mentioned earlier. And for those who are possibly going to be wheelchair users in the future, they need to have a bladder and a bowel care program, and that is a whole talk in itself, how to get that to happen well in a rural place. Skin care, joint mobility, and they need to believe in their own agency as drivers of their own health and life, and then assisting them to return to the impact in the world around them, and you need to know their home to do that. Another really important thing in terms of managing and following up with patients is telling them what their predictive course of healing is. And Madeleine and Nori both spoke about this. They need to gain weight, and you need to have a measure to tell them that they've got a predicted future of healing ahead of them. You need to know what they're improving from. So it's really important to have those baseline measures. Madeleine also mentioned that. So those are the ones up there. You won't know that they're improving if you don't have the baseline details. So find out what those are in the beginning. And if they're not following a predicted course of healing, refer back. There is a risk of treatment non-response or MDR. And then just lastly, multi-drug resistant TB is encountered in 3% of all new cases and 12% of retreatment cases. And so is there the risk of that? And the second thing is recurrence of TB. The recurrence rate for skeletal TB in some studies was 2% of patients, and they need to understand this risk, and you need to consider that when they present later on with back pain, that it's not necessarily only a mechanical thing. It could be a TB recurrence. So that's just the last thing. And then Madeleine mentioned the iris. So just check that. People who have the paradoxical reaction to treatment, that they don't, they're on the right treatment and everything, but however they seem to be deteriorating despite that, and that's definitely worth keeping eyes on. Thank you. That's all. Sorry it was so quick. I know I speak fast, but I was under pressure.
Thanks very much, Karen. Although I don't think you can do slow. You're good at fast. But there was lots of amazing nuggets in there. What we will do is, I'm sure everybody will be happy for their presentations to be shared. So we will put those together, and there will be a recording that we'll be sending around as well. We just want to quickly see if there are any questions. At the moment, there's none in the chat, but I just want to check with the participants if there are any questions, to please put your hands up, or if you're struggling to find the hand button, to unmute yourself if there's questions you want to aim at any of the three of us regarding spinal TB.